we're running a bit short on time. I suggest we keep questions to the end discussion, and we'll step right on to welcome Lieutenant Colonel Tom Clack to tell us about the human aspect. Tom has a background as a GP in the military, but has always had an interest in sports medicine and has developed that within the military over the last 20 plus years. And as you can see from his build, his preferred sport is not riding, but possibly rugby or something similar, and is about to embark on a tour, he tells me, with the British Army rugby team down to the South Pacific. And it coincides with another team from the British Isles heading down to a place called Australia. And I think they're all hoping to compare notes at the end of it.
Yes, I certainly hope so, yeah, I certainly hope so. Thank you for the offer to come and speak. Completely, it was unexpected, and I have some colleagues who are vets, and because of my interest in tendinopathy, I think that's why I had the invite. I have the unfortunate task to go after a professor, so some of the bits that he's already spoken about with his vast knowledge, I will be able to skim over to shorten my presentation because I referred to some of the same people and some of the same research. So I currently work in shape. I'm a GP by background. I've done a bit of sports and exercise medicine, working with relative sports teams in football, cycling, rugby union and rugby league. And so I've done a research project in pre-screening before doing training. And so I think that's one of the other reasons why I was asked to speak. I can't speak about that part of the project because it's behind a firewall for military reasons, but the generic research and hopefully moving on to a PhD about tendinopathy puts me in a good position to talk about it in humans. So old and new therapy is what I've deemed calling it. A lot of them are relatively old now anyway. And I wanted to start off first with a disclaimer. Let's go to next. Yeah, that works. Obviously, these are my opinions. It's not the MOD or Defence Primary Healthcare who've come up with these opinions. So please don't quote them as my parent organisations. And it's based on medicine at the moment, so those can change. There's constantly research occurring and new studies being published, and we've talked about levels of evidence. A lot of the levels of evidence at the moment are in the middle. They're not based on systematic reviews of randomised controlled trials, and so some of them, Mark was talking earlier about his expert opinion from his previous experience. That is still evidence-based. It is down the bottom of the levels of evidence, but sometimes that's the best evidence that's available. So utilise that to its fullest. There's some qualifications. I've included them for those who might review the presentation afterwards. So I briefly sweep through some of these. We talk a bit less about the background because a lot of that's been covered already. Some of the consensus statements you've heard by some of the other speakers that it's more of a clinical diagnosis, so seeing it in an image is not necessarily going to dictate that those individuals or those equine models have actually got disease, but it is a high risk factor as mentioned. I'll look at some of what is considered more routine treatments from the eccentric loading practices in the 1990s through to more heavy slow resistance stuff, shockwave therapy and the injectables that have already been discussed a little bit. And then close with some of what I deem the more research areas, which has already been talked about. So UTC, there's one bit that hasn't been talked about, which might be an area for my PhD in the future, which is looking at shear wave electrography with relation to categorising how far through rehab tendons are. Oh, sorry, back a slide. So some of these pictures have been slightly different pictures to some of the other presentations, but in essence, the big bits that look like braids of hair are the collagen type 1 fibres. They're the ones that are closely tight packed together, and you've seen some of those in some of the other pictures. One of the important bits is this guy here, a tenocyte. So that is one of the tissue that helps mop up and repair bits around the tissue or helps strengthen the areas of what's considered normal tendon around areas of bad tendon. And then these bits are the extracellular matrix, so lots of proteins and bits that make up the structure of the tendon. So I briefly said I'd talk about the timeline and the background. So Hakan Alfredson in the late 1990s came up with a specific way of managing and returning people to sport, and the same level of sport that they'd started previously, but over a long time. So it was a 12-week program of 3 sets of 15 heel raises, both bent knee and straight knee, twice a day for 12 weeks. So that's a significant amount of time off legs. Previously, that was stop all sport and just do that to return yourself to running. And it had really, really good results. So what did they do? They started to use that in other tendinopathies. So shoulder for volleyball players, elbow for tennis players and golf players, knee for more jumping sports. But not all tendons are exactly the same. So they didn't all respond in the same fashion. So they then explored whether or not avoiding excessive eccentric whilst it's getting longer, concentric whilst it's getting shorter, would improve the outcomes in some of the other tendons. Moving on to the 2010s, more deeper work understanding what's deemed a tendinopathy continuum. So what do we mean by that? That is imaging a tendon, it looks like it's bad, looking at a tendon, it looks like it's swollen, all the way through to significant symptoms, which is preventing you from doing the activity. And in the equine model, that's probably limping or lameness. In the human model, that's probably limping or lameness. So you can see where there's some overlap. And then finally, the 2020s, some of it happened in the late 2010s, but shockwave therapy, as you can see, UTC was used early as well, earlier, I would say, in equine models than was used in human models. And that helps with monitoring. The idea behind it is trying to help predict return to activity for the human model. But the key thing was, and Professor Roger mentioned it, treating each of them as an individual. So it's not, this is the stock thing you're going to do to get better. It is, we have to shift how much rehabilitation we do and how much loading based on the response of the individual patient or horse. I can brush over this really, really easily now because a lot of it's been mentioned in previous presentations, but if you take one thing away from the slide, this bit's quite useful. So in normal people, I would argue in normal equine models, you're going to have this going on all the time. There's a normal amount of load, there's a little bit of extra load. When you optimize that load, that allows the tissue to adapt. We talked about collagen fibers, and when you're moving from one into the other, you can see that when the tendon disrepair occurs because you've had an excessive load or there's been an increase in load over a longer period of time. So one of the differentials of why you might develop tendinopathy is a study was done on scanning lots of tendons from individuals who did high-level or medium-level collegiate athletes over a longitudinal career, and they found that the highest marker of whether or not you had tendinopathic tendons was how long you'd done it for. So those in the average age of those that had tendinopathic tendons were in their 20 years worth of running, and if you average 7 years of running, you were less likely to have a tendinopathic tendon. So time will also have a key factor on whether you develop clinical evidence on imaging that there is tendinopathy. And so you're moving through tendon disrepair, and so the reactive phase when it first happens from tendon disrepair into what's considered you can't get back from this, i.e. that area of the tendon is not going to work anymore, so you either have to recruit extra areas of the tendon to do the job, so the tendon might swell, or does that make the tendon weaker? Is it more prone to rupturing? And so there is some movement backwards and forwards with some of the tissue due to remodeling, but as Professor Roger pointed out, you can do at autopsy or when you've got cadaveric models, you can look at them and it's still got a lot of the things that it may have had when it was ultrasound imaged earlier on in life. So the consensus in human model is it's a clinical diagnosis. You don't necessarily need an ultrasound to tell you if there's tendinopathy, and that harks back to what was spoken by our first speaker this afternoon. If it looks like it's bowed, it's probably got tendinopathy or superficial digital flexor tendon injury in a horse model. And same goes for a human model. If it looks like it's swollen and the patient goes, it hurts when I squeeze over that area, and when they move their ankle, that area moves slightly, that's the tendon. If it stays in the same place, or if it's right at the heel then there's lots of other differentials, and particularly in the Achilles tendon in human model, there's an insertional. There's almost even two types of Achilles tendinopathy. There's the mid portion, which is 2 to 6 centimeters distal, proximal to the calcaneum, and then there's insertional, and they will go, it's here, right on the heel of my bone where it's sore, and that doesn't move. So what happens? Overuse, overloaded, that causes pain, swelling, and loss of function. You've got a clinical diagnosis. You don't have to ultrasound or image to say that that's tendinopathy, and therefore you would start the treatment. Those three things are likely to cause decreased strength. And so this is an image very similar to one of the images on the previous presentation, but on ultrasound you can see here, these are the things you're looking for on a tendinopathic tendon, if you have access to ultrasound or you've seen one. So it's going to look swollen, it's bigger, normal tendon, abnormal tendon. These are the bits you would see in the tendon. So the red area is it's hypoechoic. The fibrillar band-like architecture is disrupted in that area. And if you were to do a Doppler in some of the videos you've seen in a previous presentation, it will light up like a Christmas tree in the acute phase. And so that's neovascularization. And they think that with these new blood vessels comes new nerves, and the new nerves are what makes it painful, as well as the stretch on the outside of the tendon. But what you also notice is here. Now, it's not pristine and shiny and reflective like the good tendon on the left-hand side, but it's still of a similar width, and it's still relatively running in the same direction. Routine treatments. So again, it's been talked about, but the goal is you want to return either, if you could, return the tendon to a tightly packed tendon that has exactly the same properties as before an injury. But it's well reported that not all of those tendons are going to get back to that level. And some of the work from Dr. Dorking from Australia looked into doing some of that analysis with ultrasound tissue characterization, looking at, there was a systematic review that he reviewed as part of his research project that looked at imaging lots of tendons of people who did sport, and it culminated all of those research projects into a structured systematic review, and it revealed that of the tendons that were imaged, only 20% of them of those people were symptomatic. So you've got 4 times as likely to not have symptoms as have symptoms, even if you had a tendinopathic tendon. And the image that the video clip that was shown of David Beckham, he had reported that he didn't have symptoms in his Achilles tendon before he ruptured it. So he probably had tendinopathic tendon, and it probably was one of the reasons why it ruptured, but he wasn't symptomatic. Now, was that the training and load that he'd been doing over a number of years, or was that because he was genetically predisposed not to feel the same features that someone might feel if they had a tendinopathic tendon, the 20%, 80%. So yes, I keep getting segued. So eccentric loading of the tendon. The basic principle is you are loading that tendon whilst it's getting longer to try and stimulate the tendon to repair in that fashion. Or that's the theory behind it. And what you need to gradually progress that, because you can't just have a prolonged period of just elongating this tendon. Previously it was this is going to be 12 weeks. I'll come on to what they do in the future, but you would still have a structured progressive program on top of the eccentric loading. The normal bit of returning normal function, thinking about just routine stretches to get that joint moving in a normal fashion once you've settled down the acute inflammation. So placing ice there. The first 2 weeks of normal, most people's acute reaction is a pneumonic mice, gentle mobilization, icing, compression, elevation. I would add to that, after the first 48, 72 hours in human models, adding in an NSAID, because you want some of that, you want some of the recruiting of tissue modulators to try and repair a tendon if it's damaged. So if you turn it off straight away, you might dampen the ability of the body to repair itself. And that goes for corticosteroids too. Once that acute phase is settled down, then you move on to the more structured progressive load. And as in future treatments, each bit is individual for an individual patient. So progressive tendon loading protocols are the bits that have changed the most since its initial outset. So there's not just the talk about eccentric loading, there's now isometric loading, isotonic loading, concentric loading, and that is shifted depending on how the individual responds to that load that's applied to them. The defence has something called a best practice guidance for lower limb tendinopathy, and again, it dials up and down which area of that rehab occurs first. It's already been demonstrated that this is something that is already widely used in the equine models and in elite racehorses. The one caveat for your cohorts is you guys have less time, because a racehorse lifespan is shorter, and an adult male or adult female who's doing activities maybe has 20, 30 years worth of time to be able to do what they need to do from a sporting level. More modern treatments. So we talked again about the progressive loading, but the analogy that has been used more often from the mid sort of 2010s onwards is trying to think about the tendon as a donut. And when it's healthy, it's a full normal donut, and all the fibres are running nice and normally. It hasn't got jam in it or anything. It's just a full donut. Areas that are tendinopathic are like the hole in the donut. So as long as the donut is still sufficiently intact, the hole in the donut, we don't need to worry so much about. We need to treat the symptoms that are preventing them from using that tendon, which might be pain and swelling, but we're not specifically trying to readjust what's going on in that hole. We're trying to strengthen the other area of the donut by using that progressive load. Shockwave therapy and lots of the other injectables, corticosteroids and PRP, what you're trying to do is stimulate a response within the tendon. And so I mentioned it briefly earlier, but corticosteroids do this, and the red doesn't really show up very well, so I apologise, but cortisone is going to restrict delivery of nutrients to the tissue. It's going to slow the formation of new tissue. It's going to increase tissue degradation, and it's going to damage the collagen. Now, in models that have a short lifespan, that might not be so bad. But in models that have a longer lifespan and you want to improve their longevity, that's probably more important to steer away from it. So if it's you want to get them to the biggest race of the year and they've only got 3 years of racing, then it's probably still reasonable to use that. If it's I want them to have 7 years of racing, you might want to take a hit of 3 to 6 months of rehabilitation to enable them to have longevity. But I'd add that you've mentioned in lots of the presentations already, there's not many horses after having a superficial digital flexor tendon injury that get back to that level. And you're probably counting them on the number of, on hands rather than bigger numbers. PRP has already been mentioned, but there's just oodles and oodles of growth factors. What do? They are trying to bathe the area in equine models. It's been discussed that you're injecting into the tendon. In human models, there's not advocated to inject into the tendon because there's a risk of rupturing the tendon. But importantly, it being diagnosed, and some of that work by Sean Docking, was the psychology of tendon. So if you tell, oh God, that tendon looks terrible, really, really grotty, that's the worst tendon I've ever seen, what image is that painting in the patient that you're having that discussion with? God, my tendon's terrible, it's grotty, I'm not going to be able to load my tendon, I should definitely stay off my tendon. When actually what you want them to do is to load their tendon. And you trying to explain the analogy of the donut to them might help them feel they can load that tendon safely. Some of them may rupture their tendon, but they might be the cohort that were going to rupture their tendon anyway. And so what does that do? All these growth factors bathed in that area are going to promote tissue healing, help remodeling of the tissue where remodeling can occur, increase tissue proliferation and that growth phase and healing phase, and ultimately pain control. Because if an animal or a human is painful, it's going to have a similar issue, not be able to do the function you want it to do. In a human model, you can warm them up. So a lot of people with tendinopathy will have a stiff joint in the morning, or a stiff ankle, or a stiff shoulder, or a stiff tennis elbow, or stiff knee when they first get up, or prolonged sitting. If you've been driving in a car, you get up and your knee's stiff. Generally, when you start it moving, it tends to be just one of the joints. Generally, when you get it moving, you can actually do more things, and that happens when you're running too. So you can have a warming up phase to be able to run, even if you've got tendinopathic and symptomatic tendon. So there's very few times where you don't want to load the tendon at all, and that's normally just in that really acute phase at the beginning. The future research areas, again, it was used probably in animals before humans, and there's a lot more data sets and more rigorous evidence-based trials in animal models than in humans. But because of its nature, a stem cell is a pluripotent cell line. It can turn into what it needs to turn into. I mentioned about the tenocytes, and I could mention loads of different medical terms, and I'm not going to, but essentially there's lots of cell signaling that's occurring that will enable the cell to dial up and dial down what it's doing. And so it's not worth me mentioning, paracrine signaling. The tenocyte, which is a fibroblast, will release other chemicals to recruit macrophages into the area to try and nibble away at tissue that doesn't want to be there and help lay down tissue that does need to be there. That's the diagram that explains all of those long-winded chemical bits, but the important bit is it's a cell that can turn into lots of things and can do lots of signaling, and we're putting that into an area where it can try and help stimulate the repair and recruit other tissues and other cytokines into the area to repair or dampen down inflammation. Individual components of PRP, which has already been mentioned, it can either be manufactured in a factory, the biologics, and then sent out and packaged really uber-duper expensive, or the simple thing is you take a vial of your blood, you spin it round and take out the layer and put it in an area where you want it to work. So I try and simplify things. And then measuring pathways to healing, which is probably one of the big bits to talk about for the future. So ultrasound tissue characterization works out the percentage. So one of the downsides to imaging with ultrasound is it's two-dimensional. You just get an image of the probe which sends the sound waves through, and you get a reflected image of what you see below. So if you put it in the right place, you're going to see pristine tendon. If you tilt it slightly in a different direction, you either get artifact or you see an area of tendon that is the tendinopathic area. What this does is it enables you to go, okay, well, all of the green stuff, I don't know which way around the image is, all of the green stuff's really good tendon, all of the red stuff's bad. It's probably the other way around. But that enables you to percentage and say, okay, well, this percentage is good and bad tendon. But what you can also do is say, what volume of good tendon is there? So some of the work that Sean Dorking was doing in Australia looked at, he scanned 177 tendons, and he was able to say a thick tendon is a good tendon because your tendon has been able to repair itself. This isn't a human model. Your tendon's been able to repair itself. It's got thicker to enable it to spread the load. So a thicker tendon is actually not as negative as it might seem. And so the psychology of saying someone's got a really grotty, terrible swollen tendon, if it's not painful and they can do their function, it's probably reasonable to go through the training and progressive loading program to speed their return to activity. What does this show? This is one of those other things that I talked about. So shear wave elastography. So what it's trying to do is look at how rigid, and again, it's using sort of slightly modified ultrasound that is set up in a jig. So it's always ultrasound in the exact same part of the tendon when you're doing it, so that you can look at serial shear wave electrography derived images to say how much stiffer has the tendon become after we've done the treatment to it. And the idea behind that, and this is the newest area of research, the idea behind that is to see, okay, well, if it's really stiff, has it got that electric sort of ability to store the energy to do what we want it to do? And so can we then move on to the next stage of rehab? So levels 1 and 2, reduce pain and increase strength, as we talked about earlier. Level 3 is trying to think about increasing some of the dynamicity, if there is such a word, using that stretch shortening cycle for explosive jump, run, running downhill, the bits where you have 20, 25 times your body weight going through the joint. You don't want to move on to that if you still can't walk around the corner at 7 times your body weight without getting pain the next day that's worse. I don't know how you do that in a horse model. It might be easier because the horse might not move. You put the jig on to the right place and see how far through and how stiff the tendon is or how flaccid the tendon is, and it gives you a number. So you can say, this is 20 and now it's 25. And so 25 is clearly better than 20. And therefore, can you progress their rehab? It gives you a mark in the sand and enables you to compare, ideally, apples with apples. So I've tried to regain time because a lot of it's been covered in some of the other presentations, so I hope I have. But in summary, a chronic overuse injury is a tendinopathy. That's in a human model, and I imagine exactly the same in the equine model, with the bits you've been talking about earlier. The tendon in some areas is going to be degenerated, disorganized, which decreases the strength, causing pain. But not all tendons that are degenerate, disorganized, have reduced strength because it's not painful. So the tendon's adapted in the other areas, so you don't, it's a bit bigger at one side than the other because the hole's in the middle or slightly off center. So that good tendon is compensating for the tendon that's tendinopathic. The treatment is the same. Get mobility first, decrease the acute inflammation, introduce resistance exercises of different options, but eccentric is still the big primary load, although heavy slow resistance is making more of an increase as part. Progressively load it, so you want to be, before you move on to the more dynamic stuff, 125% in one leg compared to the other. Again, I wouldn't know how you transport that to an equine model. There are adjuncts. So these are not a panacea. You don't put injection to everyone and expect it's, or all horses and expect they're going to rapidly change things. The mainstay of the treatment is still going to be this with your ice and reducing pain initially. These adjuncts are the bits that boost and get individuals in a human model over a plateau phase potentially, so that the rest of their tendon can compensate. And the newest area is this: can we measure a pathway to healing? Is there an indicator, a number, a figure, a diagram that's got to be above a certain percentage of your tendon that's doing what it needs to do before you progress to the next stage, which is the more dynamic stage? They're the references. I used only open source ones to make them easy for people if they want to read them. Some of them are very boring, but the majority of them are quite interesting reads, particularly just the abstracts if you've got time. And within that, embedded within the presentation underneath it is the levels of evidence, and most of the evidence is going to sit around 3, 2B or 2A for lots of the work that's happened so far, because there hasn't been much of the structured, systematic reviews of good RCTs.
Tom, thank you very, very much. Not only have you caught up on time for us, but you have clarified to my mind why Mark and Roger are failing with the equine model. They're not telling the horses, you can get better, you will get better, which you can do with the human model. We'll break for tea or coffee now, and we will carry on in about half an hour with the final presentation and everybody up on stage for the discussion. Could I ask all the speakers to just quickly come outside for a group photograph? We've already had one with a throat lot, but I think we want to have one with all together. So go on through for tea and coffee.